Welcome to the deep dive. Think about the last time you went to the doctor. That visit, the tests, maybe even how you paid well, it all generated data.
A huge amount of data.
Right. And today, we're diving into that crucial world of healthcare data. Not just that it exists, but how it's gathered, how we know we can trust it, and what makes it actually useful.
Exactly. We're looking at two really comprehensive guides today: data collection and analysis in healthcare, and also population sampling and data collection in healthcare research.
Okay.
These really get into the nuts and bolts of how this whole system works. Our job is to, pull out the most important insights for you.
Yeah, our goal isn't to swamp you with technical jargon, but really to give you a clear sense of what makes healthcare data reliable, trustworthy. We'll explore, well, everything from the first steps of getting the data right through to the legal stuff, the safeguards protecting patient information. So where do we even start with all this? It seems massive.
Well, it really begins with coordinating the data collection. And this
Yeah.
isn't just, random note-taking. It's a structured process.
Structured how?
It's designed to help evaluate performance, monitor patient outcomes, and ultimately drive improvements in care. And modern technology has completely changed the game here.
Oh, absolutely. Electronic health records, EHRs, they're central now, aren't they?
Totally central. They allow for, well, often automated data extraction.
Which saves time, I imagine, and probably cuts down on mistakes.
Exactly.
Good.
Less human error. And it gets even more interesting because these systems are now using things like machine learning.
Right, computer spotting patterns and all that data.
Yeah, analyzing these huge data sets, it can help predict risks for patients or even figure out better ways to use hospital resources.
It's fascinating how much thought goes into just the very first step, deciding why you're collecting data and who from.
It really is. So, for instance, if a hospital wants to reduce infections after surgery, they need to be super specific. Which types of surgery? What time frame are we looking at? Define that population clearly.
Right, and then it's about who exactly gets included in that data set. Is it every single patient, or do you take a sample?
Good question. The source material really digs into different ways to sample beyond just, picking a few names out of a hat. You've got random sampling. Everyone has an equal chance. Stratified sampling.
Stratified, what's that?
That's where you divide the population into relevant groups, first, say, by age or type of surgery, and then sample from each group. Ensures representation.
Got it.
And there's cluster sampling, too, where you might select entire groups, like maybe all patients from certain wards.
The level of detail seems pretty intense.
It is. And they use sophisticated software now, like R and Python, for these complex sampling designs. Makes the data more reliable.
And you need to know how many people to include, right?
Yes. Tools like G-Power help researchers calculate the minimum sample size needed to actually find meaningful results. You need enough data to see the real picture, not just noise.
Okay, so you know who you're collecting from. Then you need to nail down what you're actually measuring.
Precisely. Defining clear numerators and denominators. So back to our surgical infection example.
Yeah.
The numerator is the number of patients who get an infection. The denominator is the total number of those specific surgeries performed. Simple ratio.
But it's more than just counting things these days, isn't it?
Oh, much more. There are standardized metrics from places like CMS or the National Quality Forum. These let you compare performance across different hospitals or clinics.
Apples to apples comparisons?
Kind of, yeah. And there's a growing focus on PROMs, patient-reported outcome measures.
PROMs.
Yeah, capturing the patient's own view of their health, their quality of life after treatment. It's really valuable, especially as we move towards value-based care.
Makes sense. Okay, practicalities. Choosing the tools to actually get the data. What does that look like?
It's a whole range. Could be old school paper forms, though a little less common now.
Right.
More likely, it's built-in modules in the EHR system, mobile apps for patients or staff, secure cloud platforms like RDCap,
RDCap. Yeah, I've heard of that.
and even wearable devices now, sending real-time data, smartwatches, glucose monitors.
But the guides stress testing these tools first, pilot testing.
Absolutely critical. You pilot test with a small group first, make sure the tool is easy to use, that it actually captures the data accurately, find the kinks before a big rollout, like testing on a baseline sample.
And the people collecting the data, they need training. Consistency seems vital.
Hugely vital. Inter-rater reliability, that's the term. Making sure everyone collects and records data the same way.
How do you achieve that?
Standardized protocols are key. Training sessions, maybe even simulation exercises, like using mock patient records in the EHR.
Practice runs.
Exactly. And since EHRs and standards, like FHIR, keep evolving, that training needs to be ongoing. It's not a one-and-done thing.
FHIR, that's the standard for exchanging healthcare info, right?
Fast healthcare interoperability resources, yeah. Helps systems talk to each other.
Okay, so even before you collect anything, you need a plan for analysis and display.
You really do. What statistical tools will you use? Regression models, control charts. How will you visualize it? Run charts, dashboards.
Like Tableau or Power BI?
Could be, yeah. Interactive dashboards are huge now. The key is ensuring the data format you collect actually supports the analysis you plan to do. Like if you want trend analysis, you absolutely need timestamps on the data.
Seems obvious, but easily missed, I bet.
It happens.
Yeah.
And the tech leaps are just, wow. AI using natural language processing, NLP, to pull data from unstructured doctor's notes.
So reading the text notes.
Essentially, yeah.
Yeah.
Extracting diagnoses, symptoms, and those IoT devices, Internet of Things, smart glucometers, heart monitors, providing continuous streams of data.
Real impact from this tech.
Their studies, one in 2023, Lancet Digital Health, showed AI reducing documentation errors. Another in JAMA, 2024, linked IoT monitoring to fewer hospital readmissions for heart failure patients. Real results.
But it can't all be smooth sailing. What are the common hurdles?
Oh, plenty. Data silos are a big one.
Silos.
Different departments, different systems, none talking to each other. Interoperable EHRs and standards like FHIR are trying to fix that, but it's a challenge. Staff turnover. You train someone, they leave. So standardized training and good knowledge repositories are crucial. And always patient privacy. De-identification techniques, strict HIPAA compliance. That's non-negotiable.
So pulling it all together, coordinating data collection is, well, it's complex. Needs planning, tech, trained people.
It's a whole ecosystem.
Okay, that sets the stage. Let's move to Chapter 2. Validating data integrity. We've gathered all this info, but how do we know it's, right, accurate?
Crucial question. Because if the data is garbage, the decision's based on it. Well,
Garbage in, garbage out.
Exactly. Data validation is all about ensuring that collected information is accurate, complete, consistent, trustworthy. It's the foundation for sound clinical and organizational decisions.
So what are the actual steps? How do you validate?
First step is just getting organized. Structure the data logically. Often, a single spreadsheet format works well, especially for smaller data sets. Tools like Excel, maybe Access, or SAS for bigger stuff.
Variables in separate columns, that kind of thing?
Yeah, keep it clean. Each piece of info gets its own column.
Okay, organize. Then what?
Then you scrub it. Actively look for errors.
Scrubbing, like cleaning.
Pretty much. You look for obvious errors, negative values for weight, say, or inconsistent date formats.
Like MMDDYYY versus DDMMMY.
Exactly, all those variations. And you need a strategy for handling blank cells missing data. What does blank mean?
Right, giving the data a good spring clean, metaphorically.
You could say that. Then you need to validate consistency in more subtle ways.
How so?
Using uniform terminology. Is it always no or sometimes negative? Is male always capitalized the same way? These small things matter, especially for analysis.
Tedious, but important.
It can be. Tools can help. Excel, for instance, has data validation rules you can set up to force consistency during entry.
So preventing the errors in the first place. Smart.
That's the idea.
Yeah.
And then for an extra check, you do cross-validation.
Cross-validation.
Have someone else independently review a small sample of the data, maybe 5 or 10%. Compare back the original source records the patient chart, maybe.
Spot check it.
Basically, yeah. If you find discrepancies, you investigate. Why did they happen? Might need to review a bigger sample then.
Yep.
Modern EHRs often have automated tools to help with this too.
And documenting this whole validation process seems key as well.
Oh, absolutely essential. Keep your original raw data separate, untouched.
The pristine copy.
Exactly. And keep detailed records metadata of every validation step you took, what checks you ran, what corrections you made. Creates an audit trail. Makes the work verifiable.
You mentioned Excel is still common. Any specific best practices for validation using Excel?
Yeah, the guides highlight a few. Single worksheet, as we said.
Yeah.
Keep numerators and denominators separate. Calculate ratios in a third column. For missing data, leave cells blank rather than putting in a 0. A 0 might mean an actual value of 0, which is different from missing.
Good point.
Use separate sheets for lookup codes or detailed notes. Note the data type in each column: nominal, ordinal, interval, ratio. Helps with analysis later.
Remind me quickly. Nominal, ordinal.
Nominal is categories with no order, like blood type. Ordinal has an order, like a pain scale. Interval has equal intervals, but no true 0, like Celsius temperature. Ratio has equal intervals and a true 0, like weight or height.
Got it. Thanks. Other Excel tips.
Limit who enters the data, ensure they follow strict procedures, and always enter data exactly as recorded initially. Fix it later in the validation stage if needed. Don't interpret during entry.
Preserve the original entry.
Right, and use conditional formatting. It's great for flagging outliers automatically. Like set a rule to highlight any age entered over, say, 120. Instantly visible.
Handy. These are great practical tips. What about more advanced techniques beyond Excel?
Well, we touched on machine learning for anomaly detection. Algorithms like isolation forests or autoencoders can learn normal data patterns and flag weird outliers that humans might miss. Saves time, too, according to some studies.
AI finding the odd ones out.
Pretty much. There's also data profiling tools, things like Talent or Informatica, that analyze data structure, patterns, quality, finding inconsistencies, and even blockchain is being explored.
Blockchain? For validation?
The idea is creating tamper-proof records. If the record can't be altered undetectably, it aids validation by ensuring integrity from the start. Pilot studies are happening.
Fascinating. Okay, back to basics. Common errors people actually find and fix.
Oh, the usual suspects. Spelling errors, typos use spell check, maybe text standardization tools. Python's text blob library can help there.
Dates again?
Always states. Inconsistent formats. Excel functions or Python's datetime module are your friends for standardizing them.
What else?
Out-of-range values, like blood pressure entered as 3,000 instead of maybe 130. Validation rules catch these.
Yeah.
Missing data. That's a whole topic.
How do you handle missing data?
Depends. Sometimes you exclude the record. Sometimes, if appropriate, you might use imputation techniques like filling in the mean value or more complex methods like MIC, multiple imputation by chained equations. But you have to be careful and document it.
Right. So validation isn't a quick check. It's a rigorous, ongoing process.
It has to be. It's the bedrock. Ensures the data you rely on is actually reliable.
Okay, Chapter 3, Legal and Ethical Challenges. This feels really important. Healthcare data is so personal, so sensitive.
Absolutely paramount.
Yeah.
The legal and ethical landscape here is complex but critical. It's all about protecting patient privacy and ensuring data security.
High pay comes to mind immediately.
For sure. The Health Insurance Portability and Accountability Act of 1996, and later, the HAPAT Tech Act in 2009, which really pushed for electronic records and strengthened privacy rules. These laws define how PHI-protected health information must be handled.
PHI, that's the key term.
Yes, any individually identifiable health information. Your name linked to a diagnosis, a test result, even billing information.
And these laws change, right? They adapt.
They have to. For example, there were updates to the HIPAA privacy rule in 2023 related to reproductive health data. And the rise of AI brings new challenges, potential bias in algorithms, risks of re-identifying supposedly anonymous data. It's constantly evolving.
So who's primarily responsible for managing all this PHI securely day to day?
That typically falls heavily on the Health Information Management, or HIM, department.
Yeah.
They're the experts in secure storage, retrieval, ensuring accurate medical coding, like using standardized systems. ICD-11 codes came in 2022, for instance.
ICD codes, right, for diagnoses.
Exactly. HIM manages data transmission, ensures compliance. They work closely with quality management, IT, clinicians, everyone really, especially on EHR solutions.
EHR's electronic health records, you mentioned HRTech pushed their adoption.
Massively. An influential Institute of Medicine report back in 2003 highlighted their potential, and then HATEC provided incentives. The goal was to improve efficiency, safety, quality.
What are the core things an EHR is supposed to do?
The guides list about 8 core functions, things like health information and data storage, managing results, order entry and management, decision support, electronic communication, patient support, administrative processes, and reporting.
It does a lot.
It's supposed to. And again, standards like HL7 FHIR are crucial for making them work better together. Interoperability. A 2024 NEJM study even showed FHIR standards reduced data retrieval times. Makes a difference.
Which leads nicely into HIE, Health Information Exchange. What's that about?
HIE is about securely sharing that PHI between different providers, maybe with patients, other stakeholders. It's about getting the right information to the right place at the right time for patient care.
How does that happen?
There are different models. Directed exchange, like sending a referral electronically.
Yeah.
Query-based exchange, where a doctor can look up a patient's records from another system. And consumer-mediated exchange, where patients control sharing their own data.
Benefits seem fewer repeated tests, better decisions.
Definitely. Reduces errors, saves money, improves coordination. A 2023 Health Affairs study found HIE use was linked to lower readmissions for patients with chronic diseases.
Okay, but with all this sharing, confidentiality and security are huge concerns.
Absolutely non-negotiable. Confidentiality is about privacy. HIPAA's minimum necessary standard is key here.
Minimum necessary.
Only access, use, or disclose the absolute minimum amount of PHI needed to do your specific job. Don't go browsing records you don't need for your task.
Makes sense. And security.
That's about the safeguards. The HIPAA security rule mandates administrative safeguards, policies, training, physical safeguards, locked doors, screen positioning, and technical safeguards, access controls, encryption, audit logs.
And the threats are real. Ransomware.
Huge threat to healthcare. That's why security is constantly evolving. Things like zero-trust architecture becoming more common. Assume no user or device is implicitly trusted. Verify everything.
Beyond security, what about patient consent and rights?
Informed consent is fundamental for procedures, but also relevant for data use in some contexts. Patients need to understand what's happening, and under HIPAA, patients have significant rights.
Like what?
The right to access their own PHI, request amendments if they see errors, get an accounting of disclosures who their info has been shared with. Patient portals linked to EHRs have really helped empower patients here. A 2024 study showed portals increased patient engagement.
Can PHI ever be used without the patient's specific authorization?
Yes, IPI allows certain uses and disclosures without explicit sign-off for specific purposes.
Such apps.
Treatment, payment, and healthcare operations. That operations category includes things like quality improvement activities, clinical care coordination, business planning. Also, public health reporting, like for infectious diseases, legal compliance, responding to court orders.
What about external disclosures to researchers?
External disclosures are tightly controlled. Mandatory reporting for vital statistics or abuse emergencies. Research use is possible, but under very strict rules, often requiring institutional review board approval and de-identification or specific patient consent. It's a balance. An AJPH article discussed this balance between public health needs and privacy.
And the ethical challenges keep growing, especially with new tech.
For sure, algorithmic bias is a huge concern.
Or bias in AI.
Yeah, if the data used to train an AI model reflects historical biases, the AI can perpetuate or even amplify them. A 2024 Nature Medicine study highlighted racial bias in some healthcare AI. Big issue.
What else?
Re-identification risk. Can supposedly anonymous data be linked back to individuals? Techniques like differential privacy are being explored to mitigate this. And data monetization, who profits from patient data? Big ethical questions.
So we need strong ethical frameworks.
Absolutely. Groups like AMIA, the American Medical Informatics Association, develop ethical guidelines. Focus needs to be on transparency, fairness, accountability, and keeping the patient's interests central.
Okay, let's shift gears slightly. Chapter 4, types of data and measurement. We need to understand the basics of the data itself.
Right, exactly. Before you analyze, you need to know what kind of data you have. The fundamental split is between categorical and continuous data. Knowing the difference dictates what analysis you can do.
Okay, break that down. Categorical first.
Categorical data fits into distinct groups or categories.
Right.
It's counted, not measured on a continuous scale. Two main types here.
Which are?
Nominal data, categories with no natural order. Blood type AB, AB, hospital specialty, cardiology, oncology. You just count how many fall into each bucket.
Got it. And the other type?
Ordinal data, still categories, but they do have a meaningful order or rank, like a pain scale, mild, moderate, severe, or patient satisfaction. Very satisfied, satisfied, neutral. You know one is more than another, but the distance between them isn't necessarily equal.
So with categorical data, you're often looking at percentages, like percent of patients with X diagnosis.
Exactly. Or you might use chi-square tests, frequency tables, Pareto charts to analyze it.
Okay, and continuous data.
Continuous data is measured on a scale. It can take on potentially any value within a range. Think age, height, weight, blood glucose level, length of stay in days.
Things you measure, not just count or categorize.
Right. And continuous data also has subtypes. Interval data.
Like Celsius temperature. Equal intervals, but 0 doesn't mean nothing.
Perfect example. And ratio data, which does have a true 0 point, meaning absence of. Weight, height, blood pressure 0 means 0. You can do more math with ratio data, like calculating ratios, hence the name.
And for continuous data, analysis is different.
Yes, you'd use things like t-tests to compare averages, regression to look at relationships, control charts to track it over time. Interestingly, many advanced predictive models now use a mix of both categorical and continuous data. Things like random forests can handle that mix.
Okay, so we have these data types. How do we summarize them? Find the typical value, measures of central tendency.
Exactly.
Okay.
Central tendency gives you that sense of the middle or typical value. The big three are mean, median, and mode.
Mean is just the average, right? Add them up, divide by how many?
Yep. Best for interval or ratio data if there aren't extreme outliers, like mean length of stay. Its weakness. It's very sensitive to those extreme high or low values. One really long stay can skew the average way up.
So the median helps with that skew.
It does. The median is the literal middle value when you line all the data points up in order. Half the values are above it, half below.
How do you find it?
Sort the data. If you have an odd number of points, it's the one smack in the middle. If an even number, it's the average of the two middle values. It's much better for skewed data or even ordinal data because outliers don't pull it around as much.
Okay. And the mode?
Simplest one. It's just the value that appears most often.
Most frequent.
Right. Really useful for nominal data where mean and median don't make sense, like the most common patient complaint category. You can have more than one mode, too, bimodal, multimodal.
Software helps find these easily.
Oh, yeah. SPSS, R, Python, even Excel calculate them instantly. And visualizations like box plots are great for seeing the median and spotting potential outliers at the same time. Some newer research looks at robust measures like the trimmed mean, which ignores a certain percentage of the highest and lowest values.
Interesting. What about weighted mean? When is that used?
Good question. A weighted mean lets you give different data points different levels of importance, or weight, when calculating the average.
Example.
Maybe a hospital's overall performance score. Quality metrics might count for 70% of the score, and patient satisfaction for 30%. You wouldn't just average the two scores, you'd weight them accordingly. So if the quality score was 85 and satisfaction was 90, the weighted mean would be 0.7085 plus MES 0.3090 equals 59.5 plus 27 equals 86.5. Not just a simple average of 87.5.
Got it. So central tendency tells us the middle. What about the spread? How variable is the data? Measures of dispersion.
Exactly. Dispersion tells us how spread out the data is. Is it tightly clustered or widely scattered?
Simplest measure is the range. High minus low.
Yep, quick and easy. But like the mean, it's very sensitive to outliers, just depends on the two most extreme points.
So what else gives a better picture?
Frequency distribution is helpful. It just shows how often each value or range of values occurs. You can have simple frequency counts, group data into bins, like age groups, or look at cumulative frequency. Helps visualize the shape.
And the big one is standard deviation, right? SD.
Standard deviation is probably the most common measure of spread for continuous data. It essentially tells you, on average, how far each data point is from the mean of the data set.
So small SD means data is tightly packed around the average.
Correct. A large SD means the data points are more spread out. It gives you a standardized way to think about variability. Again, software calculates this easily std-evp in Excel or functions in Python's NumPy library. Studies use it all the time, like one tracking variability in ER wait times.
Okay, final piece here. Normal versus skewed distributions. The bell curve.
Right. The normal distribution, that symmetrical bell curve, is important in statistics. In a perfect normal distribution, the mean, median, and mode are all the same, right at the peak, and there are predictable percentages of data within 1, 2, or 3 standard deviations of the mean.
Like 68% within 1 SD, 95% within 2 SD.
Exactly those numbers. But real-world healthcare data isn't always perfectly normal. It can be skewed.
Skewed how?
Positively skewed means the tail stretches out to the right. Often happens with things like length of stay, where most stays are short, but a few are very long, pulling the mean higher than the median.
Okay.
Negatively skewed means the tail stretches to the left, maybe recovery times where most recover quickly, but a few outliers take much less time. Here, the mean is pulled lower than the median.
And knowing the skew matters.
It does. It tells you which measure of central tendency is more representative. For skewed data, the median is often a better indicator of the typical value than the mean because the mean gets dragged by the tail. Statistical packages often report skewness and kurtosis metrics to quantify this shape.
So understanding these basics data types, central tendency, spread, distribution, is crucial before jumping into heavier analysis.
It's the absolute foundation. Got to know your data first.
Right. Let's dive into that heavier analysis. Chapter 5, Statistical Analysis. Making sense of the numbers, finding relationships.
Exactly. Now, we use statistical tests to go beyond just describing the data and start asking questions like, is there a difference between these groups? Is there a relationship between these variables?
First up, the chi-square test. What's that used for?
Chi-square is primarily used when you're working with categorical data. You use it to see if there's a statistically significant association between two or more categorical variables.
Example.
Let's say you want to know if the infection rate, yes, air-tano infection categorical, is different between two hospital facilities, facility A, facility B categorical. You'd count infections and non-infections at each facility. Maybe facility A had 12 infections out of 100 patients, so 88 non-infections. And facility B had only 2 infections out of 100, 98 non-infections. The chi-square test compares these observed counts to what you would expect to see if there was no difference in infection rates between the facilities.
How does it do that?
You set up a contingency table, that 2x2 table of counts. You calculate the expected count for each cell based on the overall totals. Then the chi-square formula calculates a statistic based on the difference between observed and expected counts. You compare that statistic to a chi-square distribution to get a p-value.
The p-value, if it's low.
If the p-value is below a certain threshold, often 0.05, you conclude the association is statistically significant, meaning it's unlikely the difference you saw happened just by random chance. In our example, the chi-square might be 7.68, with a p-value less than 0.01, suggesting a real difference in infection rates. Software like R, using Joe's Got Tests, does this instantly. A 2024 study used it to look at hand hygiene compliance.
Got it. Categorical data association. What about the t-test?
The t-test is for comparing the means of a continuous variable between two groups.
So continuous data this time, like average wait time.
Exactly. Maybe you want to compare the average wait time continuous in Clinic A versus Clinic B, 2 groups. You calculate the mean wait time and the standard deviation for each clinic.
And the t-test tells you if the difference in averages is significant.
Precisely. It calculates a deed statistic based on the difference between the means, the variability within each group, standard deviations, and the sample sizes. Like chi-square, you compare this t-statistic to a distribution to get a p-value.
So if Clinic A averaged 30 minutes wait, Clinic B averaged 25 minutes, the t-test might give, say, t 2.45, key 0.02.
Right. With p.02, which is less than 0.05, you'd conclude there's a statistically significant difference in average wait times. There are different t-tests for independent groups, like 2 separate clinics, versus paired samples, like measuring the same patients before and after an intervention. Again, SPSS or Python's scipy.stats handle the math. A 2023 study used it for telehealth wait times.
Okay, chi-square for categories, t-test for comparing two means. What about regression analysis? That sounds more complex.
Regression is about examining the relationship between variables. How does one variable change as another variable changes? It can involve one predictor variable, simple regression, or multiple predictor variables, multiple regression.
Predicting an outcome?
Often, yes. Or just understanding the relationship. Linear regression looks for a straight-line relationship between continuous variables. Logistic regression is used when the outcome variable is categorical, like predicting yes-no for readmission.
How do you measure the strength of the relationship?
The correlation coefficient, often denoted as R, is key, especially in linear relationships. It ranges from -1 to +1.
What do the values mean?
+1 means a perfect positive linear relationship. As one goes up, the other goes up proportionally. -1 means a perfect negative linear relationship. As one goes up, the other goes down proportionally. 0 means no linear relationship at all.
So you might find a correlation of, say, R wheel 0.75 between length of stay and total hospital costs.
Exactly. That suggests a fairly strong positive relationship. Longer stays tend to be associated with higher costs. Regression models give you more detail, like an equation to predict costs based on stay length, maybe controlling for age, too. Modern machine learning tools like TensorFlow or scikit-learn can handle even more complex, nonlinear relationships. A 2024 study used these kinds of models to predict hospital readmissions.
So these statistical tools, chi-square, t-test, regression, are really powerful for moving beyond just describing data to actually testing hypotheses and finding meaningful connections.
They are fundamental tools for evidence-based practice and research in healthcare.
Which leads perfectly into Chapter 6, quality improvement tools, taking that analysis and putting it to work to make things better.
Exactly. QI tools are practical, often visual, methods for analyzing data, specifically to identify problems, understand processes, and drive improvement initiatives.
What are the main tools in the QI toolkit?
The classics include run charts and control charts for tracking data over time, histograms for showing distributions, Pareto charts for prioritizing problems, cause and effect diagrams or fishbone diagrams for finding root causes, and flowcharts for mapping processes. Many EHRs like Epic even have built-in dashboards incorporating some of these tools now.
Okay, let's look at run charts first. Simple line graphs over time.
Pretty much. X-axis is time, days, weeks, months. Y-axis is the measure you're tracking, like number of patient falls, wait times. You plot the data points and connect them. You usually add a center line, often the median of the data.
What are you looking for?
Trends, data consistently going up or down. Shifts, a sudden jump or drop. Too many or too few runs, consecutive points above or below the median, or astronomical points, obviously unusual values. These signal that something might have changed in the process, a special cause. Maybe ER walkaways suddenly shifted upwards after a policy change. QI macros or mini-tab software are often used.
And control charts add more statistical rigor.
They do. A control chart is basically a run chart with statistically calculated upper and lower control limits added, usually set at ±3 standard deviations from the mean, or center line.
What do those limits tell you?
They help distinguish between common cause variation, the normal expected fluctuations in a stable process, and special cause variation, which signals something unusual or specific has happened that needs investigation.
So if a point goes outside the limits.
That's a flag, signal. For example, if you're charting monthly patient complaints and 1 month spikes way above the upper control limit, UCL, maybe there was a temporary staffing crisis that month. It helps focus investigation. Control charts are huge in methodologies like Lean Six Sigma. A 2023 BMJ study used them for surgical outcomes.
Okay, Pareto charts. Named after the Pareto principle, the 80-20 rule.
Exactly. The idea that roughly 80% of the effects often come from 20% of the causes. A Pareto chart helps you visually identify that vital few causes so you can focus your improvement efforts where they'll have the biggest impact.
How do you build one?
You collect data on the frequency of different problems or causes, like types of medication errors. You categorize them. Then you create a bar chart, ordering the categories from highest frequency to lowest frequency along the x-axis. You also add a line showing the cumulative percentage.
So you can easily see which bars make up most of the total.
Right. You look for the point where the cumulative line hits about 80%. The bars to the left of that point are your vital few. Maybe you find that incorrect dosing and wrong administration route account for 80% of medication errors. That tells you where to focus training or system changes. Excel or Tableau can create these. An AJHP study used this approach.
Cause and effect diagrams, also called fishbone or Ishikawa diagrams. They look like a fish skeleton.
That's the one. They're a great tool for brainstorming and organizing the potential root causes of a specific problem.
How do they work?
You write the problem statement at the head of the fish. Then you draw main bones branching off, representing major categories of potential causes. Common categories are things like people, process, equipment, materials, environment management.
And you brainstorm causes under each category.
Exactly. For a problem like delayed transfers to nursing facility, under people, you might list staff shortages or communication issues. Under process, maybe complex paperwork. It helps structure the thinking to get beyond symptoms to underlying causes. Tools like Lucidchart or Visio are good for drawing them. A nursing journal study used them for discharge delays.
Lastly, flowcharts. Mapping out a process.
Yes. Flowcharts use standard symbols, ovals for start-end, rectangles for actions, diamonds for decisions, to visually map the sequence of steps in any process.
Like admitting a patient.
Perfect example. By mapping it out, you can often spot bottlenecks, redundant steps, unnecessary loops, or points where errors might occur. Maybe the admission process involves filling out the same information on 3 different forms. The flowchart makes that inefficiency visible. Visio or Draw.io are common tools. A management review study looked at ED workflows this way.
So these QI tools aren't just about fancy charts. They're structured ways to use data to understand systems and find concrete ways to improve them.
Precisely. They bridge the gap between data analysis and practical action.
Okay, Chapter 7, Data Visualization and Reporting. We've touched on charts, but communicating these insights effectively is key.
Absolutely critical. You can do amazing analysis, but if you can't communicate the findings clearly, it doesn't lead to change. Visuals, charts, graphs, dashboards are essential for highlighting trends, patterns, and insights that get lost in tables of numbers.
And tools are getting more sophisticated. Interactive dashboards.
Very much so.
Sure.
Platforms like Tableau, Power BI, Click allow users to explore the data themselves, filter, drill down, change views. A 2024 study in the Journal of Medical Systems actually found that interactive dashboards led to faster clinical decision-making compared to static reports.
Makes sense. Let's quickly recap some common visualization types mentioned in the sources and what they're good for.
Sure. Frequency plots, like dot plots or histograms, are great for seeing the distribution of a single continuous variable, like how long pharmacy takes to dispense medications.
Okay. Bar charts.
Excellent for comparing quantities across different categories, like infection rates compared across different hospital departments. Easy to see which is highest or lowest.
Pie charts. People seem to love or hate them.
Yeah. They're best for showing proportions of a whole when you have just a few categories, like the percentage breakdown of different types of infections within one department. But they get cluttered easily if you have too many slices.
Run and control charts.
We covered those essential for tracking performance over time, looking for trends and signals of change, like charting patient complaints month by month.
And Pareto charts again.
Yep, for prioritizing. Visually showing the biggest bang for your buck issues, like the main causes of medication errors we talked about.
So choosing the right chart for the job is important. What about general best practices for making visuals clear and effective?
Clarity is number one. Use clear, concise titles. Label your axes properly, including units. Use legends when needed, but don't overdo it.
Keep it simple.
Absolutely. Avoid chart junk, unnecessary 3D effects, distracting backgrounds, too many colors. Let the data speak for itself.
Consistency.
Yes. Use consistent scales, color schemes, and formats across related charts so people can easily compare them without getting confused.
Interactivity.
If using dashboards, make them intuitive. Allow filtering, drill down so users can explore.
And accessibility. That's increasingly important.
It really is. Think about colorblind users. Avoid relying only on color distinctions. Use clear fonts. Follow accessibility guidelines like WK 2.1 where possible. Make sure everyone can understand the insights.
So good visualization isn't just about aesthetics. It's about effective, accessible communication of data-driven insight.
Exactly. It turns data into understanding and, hopefully, action.
All right. Chapter 8, Comparative Analysis. Using data not just internally, but to see how you stack up against others. Benchmarking.
Yes, comparative analysis is crucial for context and driving improvement. Organizations need to know if their performance is good, bad, or average relative to relevant comparisons. The sources outline 4 main goals or types of comparison.
What are they?
First, comparison Damon tail. Over time, looking at your own internal trends. Are your monthly infection rates going up or down? We saw this with run charts.
Oh, okay. Internal trends.
Second, comparison with peers benchmarking against similar organizations. How does your hospital's readmission rate compare to others of similar size and type?
Third,
comparison with standards measuring against established regulatory or accreditation benchmarks. Are you meeting the targets set by, say, the Joint Commission or CMS?
and fourth,
Comparison with best practices looking at evidence-based guidelines or top performers identified in research. Are you adopting proven strategies to achieve the best possible outcomes?
where do organizations get the data for these comparisons, especially the external ones?
There are several key resources. We mentioned CMS Hospital Comparator. That's public data on quality measures for hospitals nationwide. AHRQ, the Agency for Healthcare Research and Quality, provides quality indicators. And there are private companies like Vizient and Premier that offer detailed benchmarking databases and analytics, allowing hospitals to compare themselves to specific peer groups. Research publications also highlight best practices.
Does this benchmarking actually lead to improvements?
Studies suggest it does. A 2024 Health Services Research study, for example, found that participation in benchmarking programs was associated with reduced mortality rates. Seeing how others perform can be a powerful motivator.
Let's use that surgical site infection SSI example again. How would a hospital apply these 4 comparisons?
Okay, great example.
Over time.
They'd use a run chart or control chart of their own monthly SSI rate. Maybe they see a 10% increase from 2023 to 2024. That's the internal trend.
With peers.
They'd pull data from CMS Hospital Compare, or maybe a Vizient report. They might find their SSI rate is 15% higher than the average for similar facilities. That's the peer benchmark.
With standards.
They'd check the performance requirements from their accreditor, like the Joint Commission. Maybe they find their current rate is below the minimum acceptable benchmark.
And with best practices.
They'd review the latest clinical guidelines and literature on SSI prevention. Maybe they identify an enhanced sterilization technique they aren't using. They adopt it, track their data, and hopefully see an improvement, maybe a 12% reduction in SSIs over the next 6 months.
So it's a continuous cycle. Measure, compare, identify gaps, implement changes, measure again.
Exactly. Comparative analysis provides the context and direction for that quality improvement cycle.
We've covered so much ground. Let's wrap up with Chapter 9, Future Directions. What's next in the world of healthcare data?
It's evolving incredibly fast. Emerging technologies are poised to make a huge impact.
Like AI and machine learning.
Definitely. We're seeing more sophisticated predictive models for disease risk, treatment effectiveness, operational efficiency. Also, the Internet of Things and wearables, continuous real-time patient monitoring, generating massive amounts of data.
You mentioned blockchain earlier, too.
Yes, for secure, transparent, patient-controlled data sharing. Still early days, but potential is there. And even further out, things like quantum computing could eventually revolutionize drug discovery and truly personalize medicine by analyzing data at unimaginable speeds, maybe by 2030 or beyond.
Wow. What about policy and regulations, keeping pace?
Well, there's a huge ongoing push for interoperability, driven by laws like the 21st Century Cures Act and ONC rules in the U.S., mandating easier, secure data exchange.
Privacy rules evolving, too.
Constantly. Proposed HIPAA updates are always being discussed to address new technologies and patient needs. And globally, there's movement towards adopting international standards like WHO's ICD-11 for diagnoses and SNM-NCT for clinical terms, which helps with sharing data across borders.
And the ethical considerations aren't going away.
If anything, they're becoming more critical. Ensuring equity in AI, avoiding biased algorithms that worsen health disparities is huge. Empowering patients with access and control over their own data via patient portals and APIs, and demanding transparency in how data is used and by whom. A recent Lancet editorial called for global collaboration on ethical AI guidelines in healthcare.
So the future is exciting technologically, but also requires careful ethical navigation.
Absolutely. The potential is immense, but so is the responsibility.
Well, that brings us to the end of this deep dive into the world of healthcare data collection, analysis, and use. We've really gone from the foundations,
Defining purpose, sampling, choosing measures,
through ensuring accuracy with validation,
scrubbing consistency checks,
navigating the crucial legal and ethical rules,
HIPTA, PHI, consent,
understanding the different types of data and basic stats,
categorical, continuous, mean, median, SD,
using powerful tools for analysis and quality improvement,
t-tests, regression, control charts, Pareto,
the importance of clear visualization and reporting,
turning data into insights,
benchmarking through comparative analysis,
learning from others.
and finally, looking ahead at the evolving landscape.
It's a lot, but I think the aha moment, for me at least, is seeing how interconnected it all is. You can't have good analysis without good collection and validation. You can't drive real improvement without solid analysis and clear communication. And none of it matters if you violate legal or ethical boundaries. It all has to work together.
That's a great summary. It's a whole system working towards better patient outcomes.
Hopefully, yes.
So here's a final provocative thought for you, our listener. As technology, especially AI, continues to accelerate, generating more complex healthcare data faster than ever, how do we ensure this data is used not just efficiently, but also equitably? How do we make sure it truly empowers patients in their own care journey, rather than just becoming another tool used on them? What responsibility do we all, patients, providers, tech developers, policymakers, have in shaping an ethical future for AI in healthcare?
Big questions to ponder.
Indeed, something to think about. Thanks for joining us for this deep dive.